And if you can, Dr. Sanders, if you can kind of go walk us through these cases, kind of what your thought process was beforehand or going into the case, and then kind of what you did to obtain a reduction and hold it.
Sure. So this case, this is a more geriatric case. This is someone in their 70s, low energy fall, intertroch fracture. And so this is one, it's sort of on the border of stability. It's a pretty simple standard obliquity IT fracture, but the lesser trochanter is fractured off, that posterior medial calcar is fractured off. Yeah. And so this is one where you get into a little bit of a debate. Would this be adequately treated with a sliding hip screw? There's a lot of people that say, yeah, it probably would be. Would this be adequately treated with a short cephalomedullary nail? I think most people agree that this would be fine for a short cephalomedullary nail. My tendency is to use long nails for a variety of reasons, one of which is it's a training institution. I think putting in long nails and practicing freehand interlocking is really valuable for the residents. I know it was for me when I was a resident.
Right.
If they want to put in short nails when they're out in practice, more power to them. I was trained on Intertan, and so I've become a little bit of a believer in Intertan. You may see, maybe I violated one of the principles of hip fracture treatment here. You could argue that the lag screws are a little bit low on the AP view.
Okay.
That's where I tend to put them for these fractures, because that's usually where these folks have the most dense bone, is along that inferior femoral neck. Yeah, maybe we're just a hair off, but not too bad. We got the fracture in nice alignment. It's not in varus or anything. And then I think on that middle X-ray, the interesting thing to look at is, so this is someone who's in the lateral position on a fracture table. The X-ray, there's a little more going on. There's a little more that gets in the way of the X-ray, but the anterior femoral neck really lines up with the anterior cortex of the femur. The posterior femoral neck really lines up with the posterior cortex of the femur. And then you see the greater trochanter has a really, really broad profile. It really flares out both anteriorly and posteriorly. So it's useful to be able to look at that on an X-ray. So I think we got a nice reduction on the lateral view. We got a long locked nail.
Perfect. Yeah, that looks good. I like it.
Yep.
Went on a union. I like it. That's what we all. Yep. Yeah, perfect for the post-ops.
Exactly.
Yeah, looks pretty good. All right, what do we have? This one definitely looks a little unstable. Just
so this is a little different flavor. This is a lady in her 20s who's in a high energy car accident, and just as you hit on it, it's a really unstable fracture pattern. It's kind of subtroch pattern. The proximal femur is split into really three fragments. There's the head and neck fragment. It's got some trochanter on it. It's got a big piece of the troch busted off laterally and posteriorly, and the lesser troch is off, and then the shaft, the proximal segment's really displaced with respect to the shaft. So this is kind of your classic subtroch, high energy subtroch. It's got abduction, external rotation, and flexion. And so it's a hard fracture to reduce, but the one benefit you have here, because she's young and healthy, she's going to have really good bone quality. So this is a scenario where I say we don't need a geriatric hip nail. We need something that's probably more like that trauma reconstruction nail.
Right. And were you thinking before? I mean, you're probably not gonna be able to get close reduction on this. So you're thinking beforehand that you just went ahead and that same incision that you would have used to put those two screws in, you just went ahead and make an incision there and reduce this.
So yeah, I think I always hope for the best and prepare for the worst. So try a closed reduction, move on to sort of percutaneous manipulation, but prepare for open measures if you need. This is one, it went mostly by sort of percutaneous manipulation. So you see, the fracture doesn't look perfect. The trochanteric fragment is displaced a little bit still, but we realigned that medial calcar pretty well. On the lateral view, same deal. The anterior neck is lined up with the anterior shaft. The posterior neck is lined up with the posterior shaft. The trochanteric fragment is blown out posteriorly. We got two good screws deep and central in the femoral head. And then we double locked it distally. So again, we got a functional reduction. We got length, rotation, alignment, and good fixation.
Did you do percutaneous screws laterally or not screws? I'm sorry, percutaneously reduce this laterally, or did you have some anterior, stab wounds that you had to use in order to bring some of these pieces around?
Did it pretty much all laterally, but I'm not hesitant to make other adjunct incisions where we need to. I think the proximal femur is highly tolerant of that. So wherever you need to place fixation, you just want to know where the important stuff is. You don't want to wander too far behind the greater trochanter, and you don't want to wander too far medially.
Like it. Looks good. Yeah, these post-ops look pretty good too.
Yeah, same
Very
deal.
good. Went on the heel.
Mm-hmm.
And then what do we have in this last case here?
Yeah, so another geriatric fractures, guy's in his 60s, fall from standing. I think this one's interesting for a couple of reasons. If you look at his other hip, he doesn't exactly have normal hip morphology. He's got a fairly varus alignment. He's got sort of a cam morphology, if you're a hip preservation fan.
Yeah.
And then his fractured side, this is one it's a little hard to tell what's going on. You look at it, you say, boy, it doesn't look like the normal standard obliquity intertroch. And this is kind of common. It's really a reverse obliquity type intertroch.
Okay.
It starts off lower in the lateral cortex and exits higher on the medial cortex. So this is one, it's less stable. It's not amenable to a sliding hip screw. Probably not amenable to a short nail because it extends down into the diaphysis a little ways. So this is one, the reduction may be a little bit difficult, but you probably ought to use a long locked cephalomedullary nail for the repair of this one.
Now, did you get a CT or anything before this case, or you just plain X-ray films?
Yeah, just plain X-rays. Okay. At this point, I feel reasonably comfortable with what I'm looking at, and I know ultimately I'm going to fix it with a long locked nail. So I've already made up my mind about the fixation going into it. It's the reduction maneuvers that may vary. So same thing, looking at all those critical elements, the center of the femoral head is at about the same height as the greater trochanter, so it doesn't look like we've left him in varus. That medial cortex seems to be well aligned. On the lateral view, the cortices of the neck are aligned with the cortices of the shaft. Again, I violated the tip apex distance rule. I probably put the screw a little bit low. But this is more of a reverse obliquity. It's not your standard IT fracture. So this one screw had a lot of purchase in the proximal fragment.
Very good. Yeah, I mean, that looks good. These are all, great cases. I definitely appreciate you coming on and speaking on this podcast. I think it was a great talk. We definitely went over, a bunch of different treatment options for intertrochs. Is there anything else that you think a listener should get, regarding these intertrochanteric femur fractures before we wrap up here?
No, I think it's a good topic to cover because it's something we're all going to treat at some point in our career. It doesn't matter what type of practice environment we're in. I think it's a good thing to become proficient at these because these are some of the most sensitive patients we take care of. Someone who's elderly and infirm is not going to do very well if you don't give them a good reduction and sensible fixation. They're going to have pain. They may go on to non-union. They may never mobilize out of bed, and that has real implications for these. So I think this is something we should all pay attention to and hopefully get pretty good at.
Well, that's great. Dr. Sanders, again, I think this was a great episode. I hope the people listening to this learned a lot. We always, at the end of our shows, we always, put away, whether it's social media or email or anything, if you want to share it, that you want our guests to be able to reach you at or follow you or anything, feel free. If you want, share your email address or your social media, if you want people to follow you there, if anything you have.
Sure. We're at UT Southwestern Ortho on Instagram. Feel free to follow us, learn a little bit about the residency program.
Perfect. Well, thank you all again for listening. I hope you all enjoyed this episode. Please don't forget to hit that subscribe button, and we will see you again next week.